Please welcome Professor of Neurology, National Institute of Mental Health and Neurosciences, Bangalore, India, Professor Sarwarna Aladi.
So very good morning to all of you. And even before we begin this morning's plenary session, I have the pleasure of recognizing the winner of the Bill Thies Award that recognizes distinguished service to iStart. The award honors William Thies, who passed away on August 16, 2020. During his tenure from 1998 to 2020 as the Alzheimer's Association's Chief Medical and Scientific Officer, and then later as its Senior Medical Science Advisor, he was instrumental in bringing AAIC under the umbrella of association activities. He played a key role in launching the peer-reviewed journal, Alzheimer's and Dementia, the Journal of Alzheimer's Association, as well as the association's Research Roundtable. During his tenure, the association's research grant budget more than doubled. In addition, Thies was committed to the creation of a professional society that gathered healthcare professionals and researchers focused on Alzheimer's and all dementias. That society, created in 2008, was iStart. We are pleased to honor Dr. Jonathan Schott as this year's recipient. Dr. Schott is Professor of Neurology and Honorary Consultant Neurologist at the Dementia Research Centre, University College London, Queen Square Institute of Neurology. Dr. Schott is a clinician scientist with particular interest in how clinical and cognitive data, imaging and fluid biomarkers, life course methods, and genetics can be used and combined to improve differential diagnosis and identify pre-symptomatic disease. He has published over 320 papers on dementia and aging and has co-edited the Oxford Textbook of Cognitive Neurology and Dementia. He holds several leadership positions, including serving as the Chief Medical Officer of the Alzheimer's Research UK. He has had a long-standing association with iStart. He was a founder member of the Atypical Alzheimer's Disease Professional Interest Area. He's a member of the Neuroimaging, Fluid Biomarkers, and Vascular PIAs, and is a past winner of the D. Leon Prize in Neuroimaging. His 8-year tenure on the iStart Executive Council, including 2 years as chair, coincided with a huge expansion in iStart membership, the number of PIAs, its scope, and most importantly, international reach, and increasing promotion of early career researchers. Jonathan exemplifies the spirit and aims of iStart, cross-disciplinary, international science that brings researchers at all different stages of their careers together to tackle Alzheimer's disease and related dementias. Please join me in congratulating Dr. Jonathan Schott, the recipient of the 2023 Bill Thies Award.
Thank you very much indeed, and I'd like to sincerely thank the Alzheimer's Association and iStart for this prestigious award and to honour the memory of Bill Thies. iStart is now 15 years old, and in that time we've seen extraordinary progress in fundamental advances in our understanding of the pathogenesis of the diseases that cause dementia, improved diagnostics, and now new disease-modifying treatments for Alzheimer's disease. These advances have been driven by better investment, new technologies, and more researchers, but also by changes in research culture. Real progress is no longer made by individual investigators, but through collaboration. Dementia research is truly a team sport. And it's this spirit of collaboration that's at the heart of iStart. From a small society with a handful of professional interest areas, each meeting for an hour or so once a year, iStart now has a vibrant membership of more than 10,000, making it the biggest grouping of dementia researchers in the world. And rather than a top-down structure, it's the membership that determines its direction, self-aggregating into 29 professional interest areas which now meet both in person and regularly throughout the year. Peers provide webinars, educational activities, mentoring, and a huge amount of original research. And in recent years, increasing links between the peers is exemplified by so many of the joint featured research sessions that we've seen at this conference. Dementia research is dependent on attracting, inspiring, and promoting the best and the brightest new talent to the field. And as well as forming a significant part of the membership, early careers researchers now serve on all of the peer committees, the iStart executive, and have their own dedicated professional interest area peers. I'd like in particular to acknowledge the purple-clad iStart ambassadors who you've seen working tirelessly throughout the week to help make the conference run so smoothly. We need, of course, to make our research and our research community more representative and more diverse. The long-standing AWARE peer has done huge amounts to promote women dementia scientists who now, quite rightly, outnumber the men at this conference. And iStart is truly global, with members from over 100 countries worldwide. The involvement of so many junior researchers and the international reach of iStart has been hugely facilitated by the Alzheimer's Association's forward-thinking move to waive membership fees for students and researchers in lower and middle-income countries, and I salute them for doing that. I'd like to acknowledge all of those who've had leadership positions and driven on the individual peers with such dedication and enthusiasm, those who've served on the Executive Council, and to my predecessors who had the vision to set up the Society. I'd particularly like to acknowledge the Alzheimer's Association staff who really make iStart work. That's Claire Sexton, Jodie Tiddener, Oz Ismail, Jamie Young, and Joanna Gracker. And on a personal note, it's been very gratifying to see iStart going from strength to strength. It's been a huge opportunity for me to forge new research collaborations, to take my research forward, and now to have a network of colleagues and friends from across the world. And as we enter a new era of dementia research, I'm excited to see how iStart will expand and develop in the years to come, and I'm confident that the collective efforts of its membership will lead to major advances and real benefits for all those with and at risk of dementia. Thank you very much.
So thank you, Dr. Jonathan Short, for inspiring all of us. And now it's my honor to announce the winners of iStart student and postdoc poster competitions sponsored by Lilly. The finalists were judged by members of the Scientific Program Committee during the poster session on Sunday. The competition is divided into the categories basic science, pathogenesis and drug development, biomarkers and clinical manifestations, and public health and dementia care. First, I will present the winners who are here with us today. The postdoctoral winner in basic science and pathogenesis and drug development themes is Ross Patterson for the poster Choroid plexus protein turnover in human choroid plexus organoids recapitulates turnover in humans measured using stable isotope labeling kinetics. The postdoctoral winner in the biomarkers and clinical manifestations themes is Heather Dark for the poster Association of Plasma, Alzheimer's and Neurodegenerative Disease Biomarkers with Brain Volume Loss and Cognitive Decline. The postdoctoral winner in public health and dementia care themes is Lydia Vake Alcazar For the poster, Cognitive Reserve in Down Syndrome, a new opportunity to understand resilience in Alzheimer's disease. The student winner in the basic science and pathogenesis and drug development themes is McKenna Williams for the poster, a twin analysis of Alzheimer's disease brain signatures and abnormal white matter. The student winner in the biomarkers and clinical manifestations themes is Melina Stark for the poster Minor Neuropsychological Deficits in Subjective Cognitive Decline, Association with Alzheimer's Disease Biomarkers and Cognitive Decline. I would now like to read out the names of the winners who are attending AAIC virtually today. The student winner in the Public Health and Dementia Care themes is Stephanie Simone for the poster Effect of Early and Midlife Cognitive Enrichment on Alzheimer's Disease Pathology and Late Life Cognition. Congratulations to all the winners. And now, it's my pleasure to introduce today's first plenary speaker, Dr. Anna Quinones. Dr. Anna Quinones is an associate professor in the Department of Family Medicine at Oregon Health and Science University. She is a gerontologist trained in health services organization and policy. Her research interests address racial and ethnic disparities in age-related changes in health, coexisting chronic disease, including dementia, and healthcare delivery changes designed to improve the management of multimorbidity for vulnerable older adults. Currently, her work focuses on the development of and the intersection between multimorbidity, disability, cognitive function, and the role that specific multimorbidity combinations play in accelerating adverse health outcomes among racially and ethnically diverse groups of older adults. Dr. Quinones will present an agenda for addressing multimorbidity and racial and ethnic disparities.
Great. Thank you so much for having me, and thank you for sticking around to the last day of the conference and joining us for our last two presentations for the plenary session. So I will focus on two issues today that form the main objective of my talk. I'll first discuss the relationship between ADRD and multiple coexisting chronic health conditions or multimorbidity. And then I'll move on and talk about and elaborate on disparities in the occurrence, the course, and the effects of ADRD across different racial and ethnic groups. But first, I need to note that I have no financial disclosures, and my funding sources are from the National Institutes of Health's National Institute of Aging in the United States. So there are well-documented, pronounced, and persistent racial and ethnic disparities in ADRD in the United States. Unfortunately, Black Americans are approximately 2 times more likely to have ADRD, and Hispanic Americans are approximately 1.5 times more likely to have ADRD. In addition, Data from the Alzheimer's Association's latest report, the 2023 report, Medicare beneficiaries, so the federal insurance program for older adults in the United States, Medicare beneficiaries are more likely than those without ADRD to have multiple chronic conditions. So beneficiaries with ADRD are much more likely to have coexisting chronic conditions than having just ADRD alone. More to the point, nearly 90% of Medicare beneficiaries have multiple chronic conditions. In addition, there are also pronounced disparities in multimorbidity with ADRD among Black, Hispanic, and Native American Alaska Native populations, including conditions that are suspected risk factors for ADRD, such as hypertension, obesity, and diabetes. This report also documented barriers when accessing care, which really should give us all pause and raise some red flags. So, 2/3 of Black Americans believe that medical research is biased against them, and only half of Black Americans trust that if we were to find a future cure for Alzheimer's disease, that cure would be equally available to them, regardless of their race, color, or ethnicity. So this brings into sharp focus that we as researchers really have fallen short. We haven't really been doing and conducting the rigorous inclusive science that includes those populations that are most affected by ADRD. They continue to be largely excluded from our ADRD research enterprise and are subsequently largely excluded from those therapeutic interventions that might most benefit them. So I'll give you just an overview of the talk today. It's broken up into 3 parts. I will start by going over some recommendations from an agenda paper that we developed around addressing both multiple chronic conditions, multimorbidity, and disparities in ADRD. I'll move on and discuss just a couple of empirical studies from our team that emphasize the relationship between multimorbidity and ADRD and the disparities that we see in multimorbidity and ADRD. And then finally, I'll move on and discuss some work that we've done nationally to think about and develop resources to be more inclusive with respect to multimorbidity and underrepresented racial and ethnic groups. So first, I want to draw attention to the recommendations that we lay out in this paper, where we really focus in on 7 recommendations. I've grouped these into 2 themes. I'll talk about those 2 themes, and also want to highlight that 7th recommendation. We heard a lot about this throughout the conference, about enhancing workforce diversity, which is equally important, but I won't focus on that in today's talk. So the first set of recommendations really focus in around applying methods that are in consideration of the full complement of chronic conditions that older adults with ADRD have. So thinking about not only their ADRD, but how their ADRD interacts with the chronic conditions that they have. And then the second set of recommendations really focus in, again, around that charge that we have as researchers and investigators at including and investigating potential options, potential treatments for those groups that are disproportionately affected by ADRD and by ADRD with their coexisting conditions. So in that first theme about considering whole person health, multimorbidity in the United States is highly prevalent and it's age patterned. This is a pattern that we see throughout the world, but these data specifically apply to US older adults. So middle-aged and older adults, approximately 2/3 of adults age 50 and older have multiple coexisting chronic conditions. And we see that it is incredibly age patterned. By the time we examine age categories, the highest age category of over age 75, we see that an overwhelming majority of older adults have multiple chronic conditions, over 80%. So we know multimorbidity is highly prevalent. We know it's associated with adverse outcomes such as disability, and we also know that it's costly for patients and their families and healthcare systems. Dementia with multimorbidity is even more prevalent. And we also know that multiple etiologies contribute to both mild cognitive impairment as well as dementia. So it stands to reason that preventing chronic diseases might be an important strategy for averting or delaying cognitive impairment. So this first study I'll talk about involves data from the National Health and Aging Trend Study. It is an annual survey, health interview survey of Medicare beneficiaries. It is longitudinal, so that once respondents are consented into the data set, they are interviewed over time. The same respondents are interviewed over time. So in this first paper, which is published in the Journals of Gerontology Medical Sciences, we sought to understand all of the specific unique multimorbidity combinations and their associations with prospective disability. So we identified approximately over 500 unique combinations, and then we aggregated those into mutually exclusive categories. So this is a histogram. It's horizontally oriented. Each of those bar graphs represents a unique multimorbidity combination that we see in those data. And they're aggregated into these 4 mutually exclusive color-coded groups. The red group are respondents that have only physical combinations of disease, such as arthritis and diabetes. The group immediately below it, that robin blue, are respondents that have cognitive impairment and at least one other physical condition. The teal blue group are respondents that have depression and at least some other physical condition. And then that dark blue group below at the very bottom are respondents that have both cognitive impairment and depression. So I want to point out that the combinations that include cognitive impairment, either with or without depression, account for approximately 24% of all of the unique combinations that we see in these data. And interestingly, in the analyses that we provide in the paper, that we conduct in the paper, the group with cognitive impairment and depression are associated with the highest levels of prospective disability. A lot of the work that our group has done has also evaluated disparities in outcomes among older adults, and we find that vulnerable groups fare far, far worse. So the next study uses data from the Health and Retirement Study. It is also a longitudinal study, so once individuals are consented and are interviewed, they are interviewed over time. The same respondents are interviewed over time. And it's a biennial community-based sample, so they're sampled every 2 years. So in this paper, we analyzed the HRS data using group-based trajectory modeling to understand the underlying latent groups or clusters of older adults that follow similar joint trajectories across 4 distinct health outcomes: multimorbidity, disability, cognitive performance, and depressive symptoms over 18 years of time, from 1998 to 2016. So once we identified these distinct groups of older adults with these similar patterns in these outcomes, we conducted multinomial logistic regressions to examine the associations of sociodemographic and health-related factors with membership in those trajectory groups. So what we found were 4 distinct groups of older adults that followed similar joint trajectories of these 4 outcomes of multimorbidity accumulation, disability, cognitive function, and depressive symptoms. So the 4 groups, they're titled at the top of each of those 4 columns. The first, the leftmost group, was the minimal impairment with low multimorbidity. The second group also displayed minimal impairment, but instead had high multimorbidity. And then the last 2 groups are groups that really fared worse. They displayed multi-domain impairment, the third with intermediate multimorbidity, and the fourth with high multimorbidity. And I want to draw your attention to that fourth group. So this group had much, much higher multimorbidity, even in earlier old age as compared with the other groups. They also had much earlier onset of functional limitations, earlier worsening of their cognitive function, and higher depressive symptomatology. And this group was associated in those multinomial regression models. The factors that were associated with membership in this group were Black and Hispanic Americans, smoking history, obesity, male sex, lower wealth, and lower education. So these are our vulnerable older adults. So main takeaways from our research thus far: addressing whole person care and well-being. We really need to be accounting for the full co-occurring disease state, personal and social contexts for older adults. Multimorbidity is much more consequential for vulnerable groups. Therefore, implementation work really needs to focus in on what works for whom and when for these diverse groups. We need to be continually moving away from acute care models and toward chronic disease models, and thinking about both community and clinical resources that can support the needs of diverse older adults. Now I'm going to turn now to some national work that I've been doing with other teams in thinking about and being much more intentional about facilitating inclusive science. There are many, many, many toolkits that we can all avail ourselves of. These are just two initiatives that have come out in the last year or two. The first is with the Aging Initiative collaboration with the American Geriatric Society. So the Aging Initiative, Advancing Geriatrics Infrastructure and Network Growth. They co-developed a curriculum. We helped with a module in that curriculum entitled Inclusion Across the Lifespan, Health Equity, and Vulnerable Populations. And really the focus here is to be thinking about these exclusions because respondents in health interview studies, in your studies, or in clinical trials might have conditions that render them excluded from these studies, but we're introducing bias here. So the curriculum is really intended on sussing out these issues and thinking through what we might be able to do in order to be more inclusive in our science. So there's a QR code. So if you're interested, the curriculum is just about complete. I believe there are just a couple of additional modules that need to be finalized. But the inclusions across the lifespan with respect to diverse populations is available. So you are much more than welcome to download that and use that for your own purposes. Now, the second initiative is with the National Institute on Aging's Impact Collaboratory, so the Embedded Pragmatic Alzheimer's Disease and Related Dementias Clinical Trials Collaboratory. And the Impact Collaboratory was really founded to build the U.S.'s capacity to conduct pragmatic clinical trials using real-world data of non-pharmacological interventions embedded within healthcare systems. The Impact Collaboratory really has come around to thinking about health equity as being very central to all the activities that we do. And that collaboration across cores has really come to the fore with a resource that we co-developed with each of the cores. So we generated a best practices for integrating health equity in pragmatic clinical trials resource booklet. These are also freely available. They're a set of guidance documents for investigators to better integrate health equity into all aspects of their pragmatic trial designs. Now, we appreciate there's a lot of complexity involved in setting up and designing and implementing your pragmatic trial. So these are framed as a first step and as guiding principles to help us all think through the steps. There are 6 worksheets. The first is getting started, so 6 best practices for getting started, and then the following 5 sheets focus in around community and stakeholder engagement, design and analysis, the selection of healthcare systems and participants, intervention, design, and implementation, and selecting outcomes. So each of the sheets has 6 recommended best practices, each of them with a main statement and then a couple of sentences of explanation to orient you on what we are thinking with that particular guidance principle. So we recognize that this is very preliminary and it's very introductory. Therefore, we are also developing an online curriculum to accompany the guide, and the curriculum provides a lot more context and even some examples to help walk you through each of these best practice recommendations. The curriculum is launching shortly. We're a little bit delayed, but we're hoping for September of 2023, certainly by the end of fall of 2023, it will be ready. And there is a citation for the best practice guidance documents in case you are able to find that with the document number identification. So in closing, I want to say that there's a great impetus to conduct better and more inclusive research, promoting greater inclusions in ADRD trials, and taking account of the complex care needs of patients with ADRD. So in that spirit, I'm gratified and happy to see that the Alzheimer's Association has an upcoming conference focused in on health equity. It's a great opportunity to share our advancements and findings. And then we've also seen a lot of this work presented here at this conference during this week. So happy to see that my colleagues at the OHSU Alzheimer's Disease Research Center have presented their work here. I hope you've all had a chance to visit and hear their presentations and other creative work that inspires thoughtful ways of advancing inclusive ADRD science. Want to acknowledge all of my co-authors and all of the people and numerous colleagues and reviewers that have improved our work, and want to thank you for having me here today. Thank you.
Thank you, Dr. Anna, for your brilliant presentation of your brilliant work that's so meaningful to diverse populations across the world as well. And now it's my pleasure to introduce our last plenary speaker, Dr. Goldie Bird. Dr. Goldie Bird is Professor of Social Sciences and Health Policy and the Director of the Maya Angelou Center for Health Equity at the Wake Forest University School of Medicine. Dr. Bird conducts research in Alzheimer's genetics with a special focus on inclusion of persons of African ancestry in Alzheimer's research. Dr. Bird focuses on using community-engaged research strategies to build trust and trustworthiness in communities that are hardliest reached for research studies and for improving overall health outcomes. Dr. Bird founded the Center for Outreach in Alzheimer's Aging and Community Health at the North Carolina A&T State University, where she also served as the department chair and dean in order to increase awareness, literacy, and engagement of communities of color around ADRD. Dr. Bird will present Inclusion in Research and Clinical Trials.
Good morning. We've come to the end. I want to thank the Alzheimer's Association for the invitation to speak with you this morning on a topic that is so important. We've had a wonderful week of learning about inclusion, diversity, and equity. And so I'm going to just share with you for just a few minutes about why we have such differences, just a little bit, and then what we all can do as researchers and and folks who actually conduct research to assure that we're getting research results that are generalizable. I don't have any conflicts of interest to declare. And as we can see on this slide, Alzheimer's is growing. It's growing all over the world, and that's not going to change. One of the not-so benefits of all of the science that we do is we're living longer. And since that's the #1 risk factor, we're going to see this more and more unless we continue to get great drugs as we're getting and get the research done that we're doing and we're learning about this week. So again, as Dr. Quinones said, AD is a health disparity. It affects Blacks twice more and Hispanics 1.5 times more, and maybe even more. Because we don't know so much about these groups, it might be even more. But there's no cure. But we are getting better about drugs, and so we've gotten 2 recent ones that we're really excited about. And we're not so excited about, though, the inclusion with these drugs, but we're going to do better. So when we look at the geographic health disparities, this is a brand new paper that just came out that looks at disparities in high-income countries due primarily to racially discriminating policies in the United States is right at the top of that. So if we look at some of the death rates in the U.S. due to these conditions, we see that it's higher in rural areas versus urban, higher rates of diabetes, as you've just seen, COPD, stroke, et cetera, cancer, suicide, maternal health, and decreased confidence in the healthcare system, as well as limited access to care. It's pretty much common knowledge that rural and disadvantaged neighborhoods are sicker. They die sooner, and they're less likely to participate in research unless we get there. So this is a very familiar slide from the Lancet, adapted from the Lancet report, that says we could probably prevent about 40% of AD if certain things are done in early, middle, and late life. And so that gives us an opportunity to begin to think about protecting the brain early by striving to eat better, exercise more, keeping our brain active, social connections, and getting enough sleep, which many of us don't do because we're science people. Except that that's easier said than done, and particularly in underserved populations. So if you look at a community where I'm from, which is in Winston-Salem, North Carolina in the USA, in that community there's an East Winston, and there's probably an East Winston in almost every state and every province around the world. And that's a place where the disparities are great in a few zip codes. But if you go just about 5 miles down the road, and in our case, less than that probably, 2.5, I think, the life expectancy may be different by about 12 to 14 years. And these are some of the reasons why, if you look on this list, the neighborhoods that these persons in which these persons live just do not allow for good health and good well-being. And so there are reasons why our science has to accommodate or look out for those persons who find themselves in these situations, in these zip codes. And of course, we heard the new report that came out that most of the Alzheimer's disease, that the counties, we now know the counties actually, where most of the Alzheimer's disease cases are. They're in Florida, in the Bronx County, and I think Baltimore County. So that's a brand new one as well. And I'll bet if we were to tease those out, to look at the neighborhood conditions and look at the histories of these people, we could just overlay these zip codes and overlay these health conditions that Dr. Quinones talked about, And it would be the same across these areas. So if we then look at a condition like the COVID-19, you can see how when people are more exposed to viruses, when people have less access, they're going to die sooner. They're going to have to be intubated faster. They're going to be in the hospital. And so these are these conditions in which people live, in which they have more exposure, they have less immunity, they have everyday stress and everyday racism and discrimination, and then years and years of just poor living. They're going to die sooner, and they're going to have Alzheimer's disease more. And they're going to be less informed about how important it is to participate in studies and trials. And then there are biases in the health system as well as biases in research. And sometimes we just don't even recognize it because we're so busy doing our work that we fail to realize what is going on in populations that don't look like us. And so this is something that was just said about the percentage of adults who believe research is biased against them, and those who believe if there's a cure, they will not be treated equitably. And so this is a real big problem, but it's an opportunity for those of us who conduct research among vulnerable populations. So I began this work about 20 years ago with Dr. Margaret Perchek-Vance, in which we really wanted to understand genetics of Alzheimer's, and really we wanted to look at it. My interest was in African Americans. And I knew that this community was really struggling with this, and really there were opportunities to learn, but didn't quite know where to get information, how to manage the disease, not even how to articulate what was going on in families. And so it was my interest to do this. So we worked together for a while, did a feasibility study, looked at the community and said, what will it take for you to participate? What do you know about it? What is your literacy level? And so we began our work by just going into the community, conducting a research program, and really found out that people were telling us they would participate. So there is this big gap then, because there was hardly anything in the literature. I think about 0.002% in the literature when we began looking at this work. So we did this study, and across an intergenerational study in the African American community, and found out that people said they would be willing to participate, and yet there was hardly anything in the literature. So we wrote this paper, and we saw that there was interest in learning about Alzheimer's disease. There was interest in getting support for care. There was interest in coming to the table and being advocates. Many people told us they just hadn't been asked. So now we have moved even further and gotten more collaborators and more people who are interested. And this is a project that's been discussed several times this week. But this is our READ ADSP study, where we really want to create a resource for studying African ancestry, Hispanic ancestry, and really African. So we have this beautiful program where we want to look at the genetic architecture, and we want to look at social determinants of health, as well as biomarkers and phenotyping in groups that are less likely to participate in research. This is really important because the largest genome-wide association studies, as you can see, have now over hundreds of thousands of individuals enrolled, Europeans. But if you look at groups like African Americans and Hispanic Americans, you can see that there's just a dearth of genome-wide association studies that in these groups. And so it's difficult for us then to generalize what we know within these populations. And then we see studies like this that continue to be printed. This one is several years old now. And it says African Americans are less likely to enroll in preclinical Alzheimer's disease. But what we have to do when we see studies like this is look into why, to the why. why are African Americans or any group less likely to participate, and have we done our due diligence with that? This is something that came out with the Us Against Alzheimer's, and we can see where the ADRCs and research centers are that conduct research. And what we find is that the counties that are most impacted may not be near the most resourced research or medical centers. And so the question is, what do we do about those individuals who need to be in studies and who are struggling with this disease, and yet they're not in the circuit. They're not getting information. They're not getting an opportunity to get the best of care, the best of opportunities for management. And so how do we reach those individuals? And then, of course, these wonderful drugs that we just talked about, we can see that there are too few people who are underserved in these trials. So, then there are people who are within those groups that we talked about, those racial and ethnic groups, people who say they are of one race or ethnicity. And then there are special groups within those groups, such as men. And it's not only African American, but men in general. But then who else might be missing? Are those who will have less education, our sex and gender minorities, those in rural areas particularly, and others with African ancestry. Are we reaching those individuals? And the answer is probably no. And so, like Dr. King, I agree, of all the forms of inequality, injustice in healthcare is the most shocking and humane. And so this is a social justice issue. It is an equity, and inclusive research is a social justice issue. So what should we do? How should we assure a diverse and inclusive research agenda? So we sometimes, and this is, I'm just speaking in generalities, which sometimes that gets us in trouble, but we sometimes recruit our participants from a performative. We're trying to get numbers. We're trying to get those enrollments that we promised NIH and the Alzheimer's Association we would get. And that works temporarily, and sometimes we get those numbers and sometimes we don't. So we believe we need to move from more of a performative, inclusive research agenda to a more transformative research agenda. And we can do this through authentic community engagement. Another one of those groups that I'm just going to group them into hardest reached communities. Sometimes we read in the literature, we call them hard to reach, but everybody can be reached. So I'll call them hardest reached communities. And this is a group to the left, to my left. We're looking in our study, our ADSP study, we're looking for African ancestry, folks with African ancestry as one group. And yet we hardly think about those Native Americans who have African ancestry. We have more Native Americans in North Carolina than anybody east of the Mississippi. And so this gives us a great opportunity. So we've begun to talk to to Black Native Americans, if you will. Great opportunity, talking to the people, the powers that be, in a respectful and authentic way, and going and showing up in the communities where they are. Again, Black men are just really underrepresented in studies, and so we've begun to reach out to communities, and particularly in what we call Tier 1 counties in North Carolina. North Carolina is divided into 100 counties, 40 of which are Tier 1, which are the least resourced, and then there are 40 more which are next, and then only 20 which are highly resourced. So we're reaching out into those communities. We're getting stakeholders into those communities to set up meetings and learning opportunities and introduction to research. We're also looking at caregivers in Tier 1 counties and people who are managing every day and having to come out of the workforce or reduce the workforce. And so we're providing educational opportunities and we've created a curriculum for caregivers who are managing patients with Alzheimer's and dementia. But we're finding ourselves in those communities. We're not necessarily waiting for people to come to us. We're going into those communities. We're finding stakeholders and leaders in those communities who are setting up opportunities for us and helping us to establish some trustworthiness. This is a group of people who we hardly ever talk about, and these are people who are on the front lines. We're finding that this was a tough year for us. Well, we're finding turnover and burnout, and we're asking clinical coordinators to do all kinds of things, and I'm not so sure we're doing a great job in terms of making sure they are good, making sure they are okay. So one of my recommendations today is to let's take care of those people who are on the front lines, who are going into people's homes, who are going into clinics, who are making sure that they are doing the work that needs to be done in a culturally sensitive way, so that people who are least likely to participate in studies can do so. So this is I just wanted to tell you that this was just a meeting we set up last year at the AAIC for our clinical coordinators across 4 sites. And they told us what they needed, and as you can see, it was a very long list. Then we brought the U.S. sites together for a meeting in Charlotte to make North Carolina, just to go over all of the things they need to know, and to also, as you can see in the red, how to take care of themselves. So I want us to leave remembering that these are the people who are on the front lines every day, and they see it. They go through a lot with their work. And so providing training opportunities for them, making sure they have the education they have, and also the self-care that they have to do this work, making sure that you have a diverse team on your research team to engage with the kinds of folks you want in your studies. This is a project that we did before the READ ADSP, where we actually looked at families. It was a family-based study, and families are crucial to research. We were able to recruit a large number of families, one of the largest cohorts of African-American families. And the way we did that was just engaging with those families and making sure that we were answering questions that they had. They can be tremendous assets in terms of getting more people in the family involved. But again, it took a very good set of coordinators, a very good trained set of coordinators, passionate coordinators, knowledgeable coordinators, and those who were sensitive to what these families were going through. We published some of this work in a recent paper in Alzheimer's and Dementia. I want to say, too, that this work costs money. It costs a lot, and it's usually more than we have in our budgets. So we find ourselves having to find other dollars to supplement this work. Authentic community engagement work costs, but it's so worth it, and the return is so huge. One of the areas that we really need to think about is language. In terms, as we are training, that's not a good word, but as we are providing educational opportunities for our coordinators, we need to make sure that they and we as investigators are using language that is inclusive. There are several references out now where we can do that. So our language, our tone, the way we approach our communities, very important to have the skills ourselves as investigators to be inclusive. I want to just share with you one project that we are doing right now. We have 4 years ago, 2019, we began to try to understand Winston-Salem, North Carolina, and that community. I was at North Carolina A&T State University for a number of years, and it's only 30 minutes down the road, but every community is different. Every community has its own set of nuances. Every community has its own culture. So we wanted to understand Winston-Salem and surrounding areas. And one of the ways we did that was we began a series of listening sessions And we did it with faith leaders. Faith leaders remain important people in terms of connecting to other people. And they have a lot of influence. And right now, they have churches that have old people. The churches are aging. The younger congregations are few. So we asked a number of pastors. We just had short sessions, hour-long sessions. We fed them the same thing. We invited them to campus. And we began talking to them about what they needed, what was important to them, how they felt about us as an institution. They didn't really like Wake Forest because Wake Forest is known for eugenics and treating people not so good, not so long ago. And so they remembered that. And each institution, each research institution has its own history. People know about it. They may not talk about it, but they know about it and they remember it. And some of those things get in the way of our inviting them to participate in research and clinical trials. So we did a lot of listening with them. The Maya Angelou Center hired, because we wanted to begin to work with faith leaders, we hired two. They weren't full-time, but we hired two on our staff. We hosted those sessions. We listened to about 25 of those pastors. We identified their church assets. We identified our assets that we were willing to lend. We hosted a retreat to begin to think about how we might go forward together. We built our membership up in order to create the Triad Pastors Network to over 100 faith leaders. These leaders were across faiths. They were small churches, large mega churches, again across faiths. They were eager to talk to us in spite of their hesitations. They're eager to talk to us about bridging some gaps between community and academic institution. So we created the Triad Pastors Network with the Memorandum of Understanding, Rules of Engagement. We co-created goals and mission values, formed an ecclesiastical council, which is the governing board. We created our own logo, which is to the right, and they had their own scripture. And then there was COVID. And so all of our plans changed. Because of COVID, we knew we needed to take care of the pastors. So the idea of the network was to do something that would improve the overall health of their congregations and their surrounding communities. And we would do that by building health ministries or expanding them if they already had one. And so we had our plans all in place, and COVID said, no, you will not. So at that point, we pivoted, and we wanted to make sure we were taking care of these faith leaders who were used to hugging people and kissing people and burying people and marrying people, and they couldn't do any of that, they all except online. So we created a number of town halls for them, making sure they were able to get the governmental funding, making sure they were able to get some mental health themselves. And then we collaborated. They asked us to do a project, which is a COVID project. And then the way we were going to build these health ministries was to, each of the pastors selected 1 to 2 congregational health ambassadors, and they were the liaisons between us and them. So these people, we developed a curriculum for the congregational health ambassadors, similar to a CHW, and we developed a curriculum for them as well. They went through a training, and then they began to launch these health ministries after COVID. This is a very powerful group of people. In our TPN, we have bishops, pastors, and bishops and moderators, and you name it, and they have a wide reach. We did not ask them to do any Alzheimer's research as of yet. This year, they will have Alzheimer's as the platform. They have invited us, because we have dealt with them, we built what we call trustworthiness, because it situates trust within us as an institution, and as researchers, not so much asking them to trust us, because why should they? And so this is really great, everything they gave us in terms of the feasibility study that we did initially with them, the listening sessions, we gave it back. The COVID project they inspired, we gave that data back to them. We're a very business-like group of people. Our council meets quarterly, and then sometimes in between, if we're doing something with them, we never do anything unless they ask us, unless we get permission from them. And so we are all about co-ownership, empowering. And the reason we wanted to do these health ministries is because when I retire, those health ministers will still be in their churches, and they will be empowered, and they will know how to reach Wake Forest and the Heart Association and the Alzheimer's Association so they can be independent. One of the fun things they did was a charity walk for the American Heart Association, and they really did a great job. They met every other week and decided how they wanted to gain that. My time is almost up. But it was the most diverse last year, and one of the largest fundraisers, and they continued to walk in teams. One of the nice things they've talked about is making sure that they are working across churches and that they're partnering and collaborating as they've never done before. So we have really created a network that is on the move, that is ready, and the congregational health ambassadors are ready to go to work. One of the things we're looking at is what does this work cost? There's a lot of effort in this. There are great returns, but there's a lot of effort and a lot of money that is needed to get into those hardest reached counties. And so we must figure out how to get into them, how to build trustworthiness, how to get them to trust us more, and that takes sustained presence. And it takes empowering people in those communities to learn about research, to learn about overall health in general, and we are plotting and planning things in their communities to assure that they are connected to us and they remain connected to us. And so this is just something I just got this week from one of the bishops who has a very wide reach. He's responsible for about 60 churches, and they're having this event. And so instead of our going looking for an event to talk to people about participating in our research, he has invited us. He's excited about our coming, and so if there's anything he can do to get us ready, he's good to go. So this is just one example of their reach and their interest now in asking us to come to their communities and support. And I'll be brief. One of the things we must do with community engagement and as we are including special populations is assess our work and find theoretical frameworks and special domains to assess what we do. Is our community engagement valuable? Is it making a difference? Is it making an impact? And we have to figure out ways to do this. This is just this was a very interesting model that the National Academies published. And then just finally, trustworthiness. As we think about the domains of trustworthiness, this is a paper by Derek Griffith. It's very important that we understand the domains of trustworthiness and really link it to trust in a way that takes some of the onus off of the people we want to trust us, but really begin to put things in place to show that we believe we can be inclusive. We believe all people, all races, all genders, all ethnicities, all folks from all areas, all the with different socioeconomic situations can be valuable people to our research. And then these are just some takeaways, things that I talked about. DEI, diversity, equity, and inclusion must be a thread, not a compartment. We must listen. When we think about inclusive research, it moves us from a deficit model, who will not participate, to critical engagement and an asset model. It's usually greatly underfunded, but it requires authentic community engagement, and we do that at the level we can. Everybody will not create a TPN, but we create whatever links, whatever bridges we can to assure that we're creating relationships that are transparent, that are honest, that go beyond the reaches of just getting numbers for our studies. We need that. That's very important. I don't mean to undermine that at all. But we have to go beyond. If we're going to be inclusive, we must go beyond getting those numbers and then going back to the lab or going back to the computer and doing it. We need many efforts to engage communities in an authentic way. It means being culturally aware of history and the things in our histories that have caused these disparities and therefore place us in a situation of distrust and mistrust. We will need to get it to a place where we understand cost and the investment and understanding how to create partnerships with community in a business-like way so that we stay in our lanes, but we collaborate and partner appropriately. It gets tough sometimes. There's strain, but that's okay. Strain is good. And then place matters, where we do this work. We cannot stay in our offices and behind our computers. We must go. And then we must manage our eligibility requirements. We've talked about that quite a bit this week. And then building that trustworthiness in a way that we build true partnerships. And the time is now. Okay, I thought I had I'm not sure what.